Hello, everyone. Good afternoon, good evening there in India. Great to be with you again. My name is Kamlesh Kunti. I'm a professor of primary care diabetes and vascular medicine at the University of Leicester in the UK, originally from India, from Porbandar, but left most of my life I've lived in India, in the UK. So today we're going to be talking about management of micro and macrovascular complications in type 2 diabetes. These are my disclosures. So I'm going to cover quite a lot of things in this presentation, give you a bit more background and epidemiology, the evidence for early multifactorial risk factor control, some data on novel therapies, and despite all the therapies we have, we don't seem to be getting them into practice. So I'll be talking about overcoming therapeutic inertia and improving adherence. There are two other aspects that will improve outcomes for patients, as well as structure education, and then summarize. In terms of diabetes, you all know it's a chronic progressive disease, increased risk of cardiovascular disease, kidney disease, non-cardiovascular disease, and premature mortality at all. And we know elevated glucose levels are associated with increased risk. People, even at diagnosis, already have micro and macrovascular complications. And cardiovascular risk is high even before they get a diagnosis or they get an event. But we know that as we move into the patient's trajectory in a journey, it becomes more and more difficult to reduce the risk of complication. That's why it's so important that we should be really targeting early. And finally, we know there is substantial evidence about glycemic control and other risk factor control, which we're talking about today. So despite all the advances in diabetes management, it still remains a challenge. Diabetes is the ninth major cause of global mortality. 54% of people with type 2 diabetes have microvascular complications. 27% or so have macrovascular complications, and about 25% have diabetic kidney disease. So these are the key aspects that really we want to treat and manage, and if possible, avoid. In terms of type 2 diabetes and cardiovascular disease, there's a really good data from the Emerging Risk Factor Collaboration that shows that compared to people without diabetes, type 2 diabetes is associated with a nearly twofold increased risk of coronary heart disease and strokes, including different stroke subtypes. However, there is good news, and the good news is that overall, because of the major advances in cardiovascular management, both primary and secondary prevention, there's been an improvement in terms of reductions in death from any cause in people with diabetes, death from cardiovascular diseases, death from coronary heart diseases, and hospitalization for cardiovascular diseases. So in the top line, green line is people with type 2 diabetes. In the bottom is the matched control population. So both in people with and without diabetes, there's been declines. But as you can see, the gap still remains between people with diabetes and without diabetes in terms of excess mortality in cardiovascular events and hospitalization. So we haven't reduced this gap over all these years. The other issue is that until now we've been really trying to manage cardiovascular complications, and that's been particularly because of our new therapies. However, we're doing so well with cardiovascular management, I think we're forgetting the microvascular diseases that people have. So this is a study we published this year using the Discover data, which is over 11,000 patients with type 2 diabetes who've been followed up over 3 years. And the uniqueness about this is these are data from 33 countries, so very representative of the global population. And as you can see on the left-hand side, all microvascular diseases are increasing, and the rates there we see of any microvascular complications of around 30 to 35%. However, on the right-hand side is any macrovascular complications, and here we see there's a reasonable flat line. So as I said, this is a prospective study. So they are occurring, but at a much lower incidence than microvascular complications. And if we look at the prevalence at 3 years, it's around 15%. So we've got double the number of microvascular complications. And I think we probably have lost that little plot that we should be concentrating in microvascular complications as well. In terms of the risk factors, microvascular complications are important for predicting cardiovascular outcomes. So this is a really good data from a friend of mine, Kaushik Ray, a few years back, showing that each additional microvascular complication is associated with the cardiovascular risk. So there is, as you see, gradation. Each additional microvascular complication, so one microvascular complications, you have about a 40% increased risk. But if you have three, you have a doubling the risk of compared to someone who doesn't have microvascular complication. And as you can see, this is much higher than the risk factors that we control, such as systolic blood pressure, LDL cholesterol, BMI, and HbA1c. So microvascular complications are very, very important. I've got a message here saying no sound, no video. Can people confirm, Anand?
I think that if the other audience are able to hear and see you.
Yeah, okay, we'll carry on. Fine, yes, Sanjeev says fine, so we'll carry on.
There should be internet issue with Dr. Singh.
Yeah, okay, sorry about that. So let's go on to risk factor control. So there's a number of risk factors that are associated with increased cardiovascular risk. We've already talked about microvascular complications, EGFR, neuropathy, retinopathy, but long duration of diabetes is also associated with worse outcomes. Albuminuria is associated with worse outcomes, and peripheral arterial disease. So ABPI, which is ankle brachial pressure index of less than 0.9. So these are people who we would assume to have peripheral arterial disease, also raises the risk as well. But from all of them, CKD as a risk factor is one of the most important risk factors. So here we looked at the risk of a cardiovascular event in people without cardiovascular disease. So at the top is the reference group. These are people with established cardiovascular disease. And is another event risk equivalent? So if you look at just CKD itself, there's about a 0.67 hazard ratio, which is so nearing someone who already has established cardiovascular disease. In the middle, when you start adding other risk factors, such as being a male, longer duration of diabetes, dyslipidemia, hypertension, or obesity, you get to about 80% risk, equivalent to someone who has already a cardiovascular event. And when you get three risk factors, it's the same as having a cardiovascular event. So CKD is one risk factor we really need to be applying for. So what's the evidence for reducing HbA1c? And we've got excellent data from UKPDS, and this was the modeling study done by Irene Stratton, showing that tight glycemic control reduces long-term outcomes. So every 1% HbA1c reduction is associated with about a 37% reduction in microvascular complications, 43% reduction in amputation or death due to peripheral vascular disease, 21% reduction in type 2 diabetes-related deaths, 14% reduction in myocardial deaths, and 12% reduction in stroke. So reducing HbA1c is important. And we've seen a number of trials over the years that have published data on whether tight glycemic control is associated with better outcomes. And these are some of them: UKPDS, Accord Advanced VADT in people with type 2 diabetes, and DCCT in the long-term follow-up, EDIC for type 1 diabetes. And basically what these are showing is that if we intervene early, like UKPDS, newly diagnosed patients, if we go for tight glycemic control, in the short term, we will have microvascular benefits. Then we will get longer term cardiovascular and indeed mortality benefits as well. While all the others, Accord Advanced VADT, were patients who'd already had established diabetes for 8 to 10 years. So when we get to that advanced duration of diabetes, we may not be able to change the cardiovascular disease risk or mortality risk, but we can reduce the microvascular risk. And the DCCT ED was in people with type 1 diabetes. And again, that showed early on we get microvascular benefits, and the longer term we can get cardiovascular benefits. So no matter what anyone says, microvascular complications can be modifiable, particularly in type 2 diabetes, and indeed microvascular if we intervene early. But there's a lot more than just glucose control. We need to have lipid control in patients. So anyone with a modeled risk, if they haven't already got a cardiovascular event, then they should be on high-intensity statins. If they're on have established cardiovascular disease, we should be putting them onto secondary prevention with aspirin. Glucose we've already mentioned. We'll come to the therapy shortly, and hypertension is very, very important as well. And this is a really nice take-home message about how many patients you need to treat. So numbers needed to treat to avoid one cardiovascular event. So as you can see, these are numbers needed to treat for 5 years to prevent one cardiovascular event. So if we reduce HbA1c by 0.9% and we keep that for 5 years, we'd need to treat 119 patients. So that's quite a lot compared to when we look at cholesterol. 1 millimole reduction in cholesterol, you need 44 patients to be treated for 5 years, and for reduction in blood pressure of 10 over 5 millimeters mercury, and you need to treat 34 patients over 5 years to prevent one cardiovascular event. So the management of lipids and hypertension are more important than reduction in HbA1c for cardiovascular events. But remember, cardiovascular, there's the issue about microvascular events we talked about with glycemic control as well. This is Usman, who did a PhD with us and looked at routine care data, showing the reference group here is someone who did not have either blood pressure, lipids, or HbA1c managed. And when we look at them, if we manage all three risk factors or in combination of risk factors, you get overall reductions in ischemic heart disease, cerebrovascular disease, end-stage renal disease, and all-cause mortality. On the left-hand side, these are people without microalbuminuria. On the right-hand side, people with microalbuminuria. But what you can see here is in terms of the cardiovascular events were not reduced with this risk factor control in this study in those people without microalbuminuria, but they were in people with microalbuminuria. But we've got excellent randomized controlled trial data from the STENO2 study. And for those who don't know, STENO2 study was people with type 2 diabetes and microalbuminuria who were randomized to tight risk factor control. So this was risk factor of tight glucose control, lipid lowering therapy, aspirin therapy, putting everyone on a RAS blocker for blood pressure. And what they shows in the short term, there was reductions in kidney disease, there was reduction in cardiovascular event, but we now have 21-year follow-up data from these patients. And what we see here is that even at 21 years, these benefits continue. So you get about a 70% reduction in stroke, you get about a 70% reduction in heart failure, and overall, patients gained nearly 8 years of life. That is phenomenal. So if we manage people with multiple risk factor control, put them onto aspirin and the RAS blockers, they can gain 8 years of life, which is just staggering. So this is what's called the legacy benefits. The UKPDS has shown that, and we'll come to that later. But the legacy benefits are not only for glucose. A lot of people talk about legacy benefits just for glucose control from the UKPDS. Legacy benefits have been shown for blood pressure, for lipid-lowering therapy, and multiple risk factor control, as I've just shown you in the previous slide with STENO2. So what about novel therapies? We know that no single anti-hypoglycemic agent can address the numerous pathophysiological mechanisms that operates in type 2 diabetes, and you know all these therapies that are available for us to manage our patients with type 2 diabetes. What combinations we bring them in all depends on the patients and their characteristics, and again we'll talk about that shortly. However, to optimally manage people with type 2 diabetes, we need to individualize these therapies based on the pathophysiological defects, and we are going to need multiple therapies. That was one thing that's very, very clear. The way we individualize, there are a number of factors to consider, and this is why it becomes really complex to manage patients with diabetes. We need to think about age, polypharmacy, incontinence, risk of hypoglycemia, sex, cognitive dysfunction, depression, body mass index. So there's so many to think about in a consultation when we're deciding people in terms of what therapy we're going to start them on. So let's look at some of the novel therapies. I'm not going to talk to all the therapies, just the recent updated data. So this is the meta-analysis of GLP-1 receptor agonists and what effect they have in terms of the component of 3-point MACE. This is non-fatal myocardial infarction, non-fatal stroke, and fatal cardiovascular events. And here what we see is looking at all the GLP-1 receptor agonists, and there are differences. There are some of the shorter acting ones at the top and the longer acting ones at the bottom. We see reductions of about 14% for MACE events, significantly in favor of GLP-1 receptor agonists compared to placebo. We've now got excellent data on SGLT2 inhibitors as well. And again, when we look at all the data put together from the SGLT2 inhibitor study, we see there's a 10% reduction, significantly in favor of treatment with SGLT2 inhibitors compared to placebo. But the remarkable data for SGLT2 inhibitors have also been for other outcomes, which were totally unexpected. And one was hospitalization for heart failure. And we've seen every study show reduction in hospitalization for heart failure. So in this meta-analysis, what they looked at was people who already had atherosclerotic cardiovascular disease and compared them to people who didn't have atherosclerotic cardiovascular disease. And what we see is an overall about 30 to 35% reduction in hospitalization for heart failure, irrespective of the person having atherosclerotic cardiovascular disease. And the other surprise, as you all know, and this was again very consistent findings, is the reductions in kidney outcomes. Now, these kidney outcomes in all of these trials were slightly different. This is pooled analysis looking at the overall kidney outcomes. And again, as you can see, about a 40% reduction in kidney outcomes. And now we've got therapies that have been approved for management of people for heart failure and kidney disease, whether they have diabetes or no diabetes. In terms of the glucose lowering medications based on these data, and this is the EASD ADA consensus report that was chaired by my close colleague and friend, Professor Davies, who sits next door to me. These were based on the evidence, and as you can see, the first-line therapy is still metformin, but then we need to think about patients if they have established cardiovascular disease, CKD, heart failure, then we should be opting for the novel first-line therapies that have the evidence base. So these are the SGLT2 inhibitors and GLP-1 receptor agonists, which I just mentioned. And if they are not controlled in terms of the glycemic control, then we should be adding either SGLT2 inhibitor or GLP-1 receptor agonist, depending on which we initiated first. If we want to reduce the risk of hypoglycemia, basically we should be trying to avoid sulfonylureas and insulin. If we want to avoid weight gain or promote weight loss, then again we should be thinking about SGLT2 inhibitors or GLP-1 receptor agonists first, and then the other therapies, but again trying to avoid insulin, sulfonylurea. And cost is always an issue, in which case if the cost is an issue, then we should be starting with a sulfonylurea or TZD. Cost is always an issue in every country, including in the UK, so we still use sulfonylureas here. So excellent evidence base for managing patients for type 2 diabetes, excellent therapies, evidence-based guidelines. But despite that, we don't seem to be winning the war. And one of the reasons for this has been termed therapeutic inertia. This is failure to advance therapy or to de-intensify therapy when appropriate to do so. Failure to advance therapy is if someone's not at target, they come to see us and we don't advance, we don't escalate therapy. That's therapeutic inertia. But also, it may be appropriate at certain times when patients have the therapy, they get old, they get frail, they get thin because of malnourishment and things. We don't stop therapies. So de-intensification is also considered as therapeutic inertia, because these patients will be at higher risk of falls, hypoglycemia, etc. And this is what we call the quaternary preventions, interventions that protect a group at risk of over-medicalization. Now, I've just shown you this before, and if I was in an audience, I would be asking you, can you put your hand up if you've seen this figure? And everyone puts their hand up. And then I ask them, how many have seen and know what that blue circle at the right-hand top is? And the majority of the people haven't seen that blue circle on the right-hand top. And to me, this is the most important area, because we can have therapies, but if we're not advancing in time, then we will have problems and run into complications. And this blue circle says to avoid clinical inertia, we call it now therapeutic inertia, we should be assessing patients and escalating therapy every 3 to 6 months. So if they're not at target, we really should be either increasing the dose or putting them onto new therapy, adding a new therapy. So just coming back to glycemic control and legacy benefits, this came, as you know, the term legacy benefits was coined after the UKPDS. And as you know, UKPDS first reported their results in 1997. And over these years, 20 years or so, patients were put into metformin or conventional therapy. The metformin arm, you can see, is the lower arm, reduced HbA1c. But no matter what they did, HbA1c got gradually worse over time. So we know that type 2 diabetes is progressive. But this difference in glycemic control between the conventional arm and the metformin arm showed those benefits I showed you about microvascular complications when the study was published in 1997. And then they followed these patients up over the following 10 years. And what happened during that time is that because of the evidence, practitioners started controlling HbA1c, and that's what you see. The conventional and the metformin arm have come together, and the reason is the healthcare professionals manage these people appropriately. But despite that coming together, you can see at the 2007 10-year follow-up, the differences in HbA1c were lost, but there was even better reductions. So there was a significant reduction in microvascular complications, which was shown at the initial results. But now there was a 15% reduction, which was significant in myocardial infarction, and a significant 13% reduction in all-cause mortality, showing that we really ought to be intervening early. And there's lots of data for this about early glycemic control. This is the EDIC study. This is a typical Ralph DeFronzo study. So here on the left-hand side, what they did was they had two arms. It was a randomized control trial. In one arm, patients went on to triple therapy straight away. This was triple therapy, which included add-on of metformin, pioglitazone, and GLP-1 receptor agonist. At that time, it was exenatide twice daily. And then they randomized them to another arm, which was the stepwise approach that we do, sequential add-on therapy, which was metformin followed by sulfonylurea, and then people going to insulin glargine. And what we see here is people who went on to triple therapy, they stayed on target for longer. So as you can see, HbA1c came down 6 months, and it stayed like that for 4 years. While in the conventional stepwise approach arm, HbA1c started deteriorating. On the right-hand side, what we see is in terms of proportion who stayed onto the HbA1c of less than 6.5%. As you can see, the triple therapy group were significantly more likely to stay on an HbA1c below 6.5%. The more interesting aspect is that despite the lower HbA1c, those people who had triple therapy from the start, not only did they reduce the HbA1c and stay there, but they had a 7-fold lower rates of hypoglycemia compared to those who had conventional arm. And this is, I think, the preservation of beta cell theory, that we preserve beta cells, we preserve glucagon when we improve HbA1c early on. So this is a really nice study from US in the New England Journal of Medicine, published last year, showing that despite all these amazing therapies we have, advances in technology, self-management blood glucose, self-management education programs, HbA1c on the left top-hand panel A has really not improved between 1999 and 2018. As you can see, near enough flat line. So top one is proportion of patients who have an HbA1c below 8%, and the blue line is proportion who have an HbA1c below 7%. And you can see it's about 50%. It's remained at 50% for over the years. And this is not the US phenomena. This is the case for UK, European country that we've looked data for as well. In terms of blood pressure, things have improved, but they've now stalled. Proportion of patients who have a blood pressure below 140/90 is about 70%. The C is lipid control. That's improved. Now, that's easy. See, lipid control is basically one tablet, statin, fire and forget, and it's easy to manage. HbA1c, as we've shown, is complex. It's progressive. We need to think about so many things when we're starting the other therapies. And then on D, what we see is management of all risk factors. Despite everything, only 22% of people have all three risk factor control. And we showed you data before about multiple risk factor control leads to better benefits. This is data from the Discover study. We published this a couple of years ago, and again, I showed you about data earlier, and this is 14,000 patients in this analysis from 34 countries, followed up over 3 years. And in this cross-sectional analysis, we looked at cardiovascular risk factor control in this global population. And I thought I'd bring this up because what you can see is the global population. At the bottom, you can see all the different countries. And in the orange yellow, what you see is Indonesia and India. So looking at the data for India, they're not the worst. There are lots of other countries that are not doing as well. But still, there's the best country, what UAE, with over 40%, just over 40% having all the risk factor controlled, while in India it's around 30%. So when we look at the global data, about only one in five people have optimal risk factor control for cardiovascular disease. We've shown this in a meta-analysis, systematic review and meta-analysis. We looked at 24 studies, about 369,000 patients from 20 countries. And the pool targets achieved in this systematic review meta-analysis was for HbA1c, this is a target of below 7%. Only 42% were achieving this. For a blood pressure target, only 29%. And for a lipid target, LDLC cholesterol target, about 49% achieving this. We've recently shown last year that if we don't see patients and manage their risk factors, so here we looked at the completion of 8 care processes, so having their eye checked, feet checked, blood pressure managed, lipids managed, HbA1c checked and managed, retinopathy checked. If they don't have that control, so this is looking at having all 8 processes managed as the reference point. If you have about less than 7 managed, then the risks are increased by about 30%. If you only have less than 5 managed, risks are increased by about 50%. And this is irrespective of age, sex, ethnicity, etc. So risk factor control and seeing these patients regularly, collecting their blood pressure, doing the HbA1c check, checking their feet, checking their eyes on an annual basis is important because it is linked to worse outcomes later on as well. So when we get all of this together, we see that therapeutic inertia is a global phenomenon. As you can see here, these about over 50 studies we brought into this meta-analysis, and whether you're on 1 therapy, 2 therapy, 3 therapy, going on to insulin, we just wait far too long. We wait anything from a couple of years, 2 years, if they're on 1 therapy, we wait anything from 3 to 7 years if they're on 2 therapies, and for insulin, we could be waiting up to 6 years before we escalate therapy despite the HbA1c being high. So does this lead to worse outcomes if we have inertia? Well, you can't do a randomized controlled trial, but you can do routine database studies, and this is exactly what we did in this study. So Sanjay Paul, who did the UK-PDS analysis, and I looked at routine data, and we basically simulated what happened in UK-PDS. We looked at the population of patients whose HbA1c came down from new diagnosis within 12 months to below 12%. And that was about 74% of the population. And we compared that to those who didn't bring the HbA1c down within 12 months to below 7%. That was 26% of the population here. And over 5 years, what we observed was a significant increase in myocardial infarctions, stroke, heart failure, and composite cardiovascular event. That's composite of all of those three events. And UKPDS termed this the legacy benefits. We call this the dysglycemic legacy, which was driving the complications. Similar data have been shown in the US for retinopathy. This is looking at patients who had progression to diabetic retinopathy. And so at the top, you see people who didn't have inertia, so they had appropriate management at the right time. And in the solid green at the bottom are people who had inertia. And as we see in this, that the incidence rate for diabetic retinopathy progression in those who had inertia was about 5-fold higher compared to those who didn't have inertia. And then finally, a study by Neda Letpong in the US again, showing that every year we wait, there's increased risk in mortality. So for example, if the HbA1c is above 8%, at 3 years, there'll be a 37% increase mortality. If the HbA1c is over 8%, for 6 years, there's a 54% significantly increased risk of mortality. So we now have data from retrospective studies showing if we do have inertia, it's associated with increased microvascular complications, macrovascular complications, and mortality as well. So what can we do to overcome inertia? Well, until now, there were no systematic reviews on this. So we've just conducted the systematic review on this, which was published last year, looked at 36 randomized controlled trials of over 22,000 patients. And what we see is the best benefits seem to be from pharmacist intervention, so pharmacists managing people with diabetes. Care managers, there was variable outcomes, as you can see in the middle. Physician assistants, variable. And nurses had physicians variable, basically not making much difference at all. And nurse practitioners, CDC trained, for example, having an effect as well. So pharmacists and nurse practitioners seem to have benefits in terms of overcoming inertia. Doctors, unfortunately, don't seem to make a difference at all. And this is, I find true, because I see this in general practice, where I practice in the UK, that we're so busy that patients don't just come with diabetes, they come with lots of other problems as well. And we're trying to manage all of that in a short consultation. While the pharmacists and the nurses have a much longer time period, they possibly are more empathetic as well. And it leads to better outcomes for these patients. And we've now got pharmacists and nurses who are managing our patients with diabetes. Adherence is another issue linked to therapeutic inertia that we can improve to improve outcomes. So there's always this thing called an evidence-based gap. So it's called efficacy to effectiveness gap. When you do a randomized controlled trial of a drug, that tells you the efficacy of that drug. When we put it into real-world clinical practice, it's called the effectiveness of that drug. So in a randomized controlled trial, this was a really nice paper published in Diabetes Care. GLP-1 receptor agonist in a randomized controlled trial. So this is the ideal setting. Patients comply with everything. They come regularly. We get about a 1% reduction in HbA1c. If we see the same drug in the real-world setting, we get half the reduction, HbA1c of 0.5% reduction. And this is, they did a really good modeling here, and they said 75% of this is because of poor adherence. In this study, they found that GLP-1 receptor agonist adherence rate in the real world was about 30% only. The other 25% were differences in baseline characteristics between patients who were in the trial and who weren't in the trial. So efficacy to effectiveness gap has been shown with other drugs. With a friend of mine called Pankaj Gupta, who works in Leicester, and he's developed a urine assay for therapies, for drugs. So we looked at over 200 patients with type 2 diabetes in routine practice who came for their routine care. And they had brought their urine sample for albumin-creatinine ratio, for microalbuminuria assessment. And what we found there is we asked the patients if we can assess their adherence as well. And overall, non-adherence was about 30% in this study. And as you can see on the left-hand side, the highest non-adherence was for statins, around 70%, and then GLP-1 receptor agonists, about 72%, sulfonylurea, about 80%. The first one's metformin, 95% adherence. ARBs, about 80% adherence. But diuretics, the last one, beta blockers, calcium channel blockers, were reasonable. So what we found that non-adherence to statins was the highest, but we also found that HbA1c, albumin-creatinine ratio, and lipid profiles was significantly higher in those patients who were non-adherent compared to those who were adherents. Why is adherence so important? Obviously, we're not going to get the benefits, the microvascular, macrovascular. And again, we've done this as a systematic review in this study of 8 observational studies, over 300,000 patients with type 2 diabetes. And when we brought all the data together, non-adherence was prevalent in about 38% of the population. And what we saw in this study was that people who were adherent, they had about a 28% reduced risk of hospitalization and about a 10% reduction in all-cause mortality, which were both hospitalization and all-cause mortality were significantly lower in those who were adherent compared to those who were not adherent. So adherence is extremely important. Now, something that we are very interested in Leicester University, we've developed structured education programs for people with diabetes. And structured education is not when they come to our clinic and we talk to them and say, are you taking the medication you should be, etc. Structured education is dedicated program, and the NICE have a criteria for that. That it should be about 6 hours minimum. They should be either group-based or individual. They should be used psychological theories, and they should be an evidence-based. And we've generated evidence-based. We developed the Desmond program, a randomized controlled trial, and that's being implemented in the UK and many other countries as well. So what's the evidence base for education programs? So this is a systematic review that was done a few years ago. Group-based diabetes self-management education programs led to clinical improvements, lifestyle improvements, and psychological outcomes. So HbA1c reduced by 0.5%, fasting plasma glucose reduced, diabetes knowledge improved, self-management skills improved, self-efficacy empowerment of the patient improved, weight improved, and treatment satisfaction improved. Just imagine if you had a drug that did all this, improved HbA1c, knowledge, depression levels, smoking cessation, which we showed. You would snap that drug up. The other issue is the cost of these are so low. The cost of a GLP-1 receptor agonist is about £100 per month. The cost of this is about £30 a year. So huge difference in cost, but they lead to all these significant benefits. But we don't seem to be putting these into practice despite the evidence base. Not only does it lead to all that, but now there's also evidence that it leads, structured education is associated with reductions in mortality as well. So this is looking at about a 10% reduction in all-cause mortality in people with type 2 diabetes. So in summary, I hope I've shown you that type 2 diabetes is a progressive disease. However, early preventative interventions and tight glycemic control, having the right therapies at the right time, is associated with short-term benefits and long-term benefits. I didn't show you the data for heart failure. Heart failure benefits occur within weeks, not months or years. Despite the therapies, we still have this efficacy to effectiveness gap in the real world setting. Patients don't have the same benefits, and there may be a number of reasons. And there's also a number of reasons of translating evidence and improving outcomes, one of the reasons being adherence and therapeutic inertia. And we therefore need lots of different solutions to try and different outcomes depending on what setting we're working in, what type of patients we're working in. So we not only need to individualize our interventions but also the therapies as well. In clinical practice, I hope I've shown you that this is what we're doing. We're yo-yoing. This is newly diagnosed patients on the left-hand side. Their HbA1c is high. We're very good at putting people onto metformin, and then HbA1c comes down. But after a few years, progressive nature of diabetes, they'll start going up, and we wait for another 2 years, 3 years, and then we'll put the second therapy. HbA1c will come down. Gradually it'll go up. We'll wait 6, 7 years and put people onto the third therapy, and then eventually wait another 6, 7 years to put people onto insulin. So these people are in chronic hyperglycemia for long term. What we should be doing is bringing from diagnosis, bring the HbA1c down, keep it low, below 7%, ideally before 6.5%, and then if it's appropriate, they have an event, they get old, they get frail, we can loosen the target later on. And this is really the holistic way of managing patients. At diagnosis, we want to make sure they have self-management education, diet, exercise plans, metformin, to avoid the early diabetes complications. As the disease progresses, we keep reviewing the patients, look at the complications, look at the new therapies. When patients are older, we need to start thinking about quality of life rather than quantity of life, because we're not going to improve outcomes when patients are elderly and frail. So maybe this is where we start thinking about lowering and stopping therapies as well. But the key is that we need to be managing patients with intensive multifactorial approach, glucose lowering, blood pressure lowering, lipid therapies, lifestyle interventions, educational programs, the new therapies as appropriate. And we really need to be aiming to reduce not only macrovascular complications, but microvascular complications as well. Thank you very much for listening. Happy to take questions. Post-lunch and dinner hypo in pre-diabetes. We don't know exact reasons, but hypo in pre-diabetes is rare. It's not that common at all. We've done some data on this earlier on where we screened the population. It was tiny percentage of patients, but we don't know. It's difficult to tell from routine clinical practice what it's due to, whether they've left their meal or not. Can patients have macrovascular complication with that? Yes, they can do, certainly. It all depends how we assess the patients. If we comprehensively assess the patients for microvascular, so doing the retinopathy screening using digital photographs, doing a pinprick test for feet, and EGFR, albumin-creatinine ratio, you do have patients who haven't got microvascular, but they had an event many years ago and then they developed diabetes. And this could be just due to insulin resistance and nothing else. Harpit Sood, SGLT2 inhibitors, what GFR can be given to? Well, this has changed dramatically over time. What used to happen was we started at 60, then it moved to 30, UK was 60 until recently. But now the new guidelines that are coming out is that we can use it to EGFR of 20. Real world data about metformin and heart failure, huge amount of real world data. In fact, the recommendation is that we can use metformin in heart failure, and that was based not on a randomized controlled trial. That was based on observational study, meta-analysis of observational studies. I think it was Silvio Inzucci who wrote that meta-analysis. And initially, when metformin came out, FDA had a black box warning that we shouldn't use it in people with heart failure and type 2 diabetes. But after that meta-analysis, they weren't going to do a randomized control trial. After the meta-analysis, they removed the black box warning, and now we can use it up to an EGFR of 30. Relationship between GLP receptor agonist thyroid cancer, I wouldn't use it if you have a risk of any of those type of cancers. OHA in pregnancy, any study. Um, Oral hypoglycemic drugs in pregnancy, what we do use is metformin and insulin. Those have been safe. There's some data on sulfonylureas, but normally it's metformin and insulin. We know we use it in gestational diabetes on a regular basis. HbA1c is 7% to 5.6% in 6 weeks on Wildermet. Expert view 70-year-old. It could happen. There are some people who have a really, really substantial impact of a particular therapy. It doesn't have to be one particular therapy. So hyper responders, for example, so you can have a dramatic reduction, but they may have done something else as well, change their lifestyle. Method of HbA1c. HbA1c in terms, I'm not a biochemist. HbA1c has to be by DCCT standards. We have a quality assurance program. In fact, everyone who's doing HbA1c, there should be an approved methodology, and this is what the labs should be doing there. So all the HbA1cs that are done in most countries are approved methods, and they also have to be quality assured on a regular basis. And we do them, if you do near patient testing, for example, we would do that monthly. Utility of HOMA-IR in non-diabetics. We don't use HOMA-IR at all in clinical practice. We've got to put patients on the blood pressure. There are other methods. Just obesity is something that is a marker for insulin resistance. Triglycerides. There've been other studies looking at triglyceride BMI ratios, but measurement of insulin resistance is mainly really for research purposes rather than doing it for clinical practice. Waist circumference, another very good measure for insulin resistance. Why is pioglitazone used less? I think for a number of reasons. First of all, you had obviously the rosiglitazone debacle had a bad press, but also because it's like a DPP-4, it reduces HbA1c, but there isn't really high quality data like SGLT2 inhibitors and GLP-1 receptor agonists for reductions in kidney and cardiovascular outcomes. That's probably the main reason. I think it's just it still has bad press from the rosiglitazone, although it's a good drug, especially for people who have insulin resistance. There was a question on insulin resistance. People who are obese, people with fatty liver disease, NASH, it works extremely well in people who have insulin resistance. What is the difference between dapagliflozin and empagliflozin with heart failure? As I've shown you, that there's consistent reduction in hospitalization for heart failure for all SGLT2 inhibitors. Now, you may see slight differences when you look at the forest plot, and that's not because this is my personal, I don't think it's because one is better than the other. Mainly it's because the population they studied were different. They're not exactly the same population. The inclusion criteria was slightly different. Empagliflozin, for example, majority of the patients had established cardiovascular disease, while in dapagliflozin, about 60% had established cardiovascular disease and 40% didn't. So there are differences there. Blurring of vision in elderly correlate with lowering sugar or retinopathy. It could be both. So if you start if someone's visual acuity was fine, the vision they weren't complaining of, and you bring HbA1c down too quickly, we know they can get retinopathy, but you've got to really bring it down quite a lot. In the elderly, you wouldn't be doing that. And what I would do is stop the therapy and get them assessed for retinopathy, um, if there is any new retinopathy occurring. But most of the studies have shown that you really need about 1% reduction in HbA1c or even greater to get retinopathy in patients when you reduce HbA1c. What is the first-line drug in morbid? I'm not sure what you mean by morbid diabetic patient. So there's been a controversy, as you know. The cardiologists came out with their guidelines saying if patients had atherosclerotic cardiovascular disease, forget metformin, put them straight onto SGLT2 inhibitor, while the diabetes camp, the ESD, ADA consensus report said metformin, then SGLT2 inhibitor. I think they're going to need both. And for now, I would normally put people onto metformin. And if patients had atherosclerotic cardiovascular disease, onto SGLT2 inhibitors. The data for metformin are reasonable. They've come mainly from the UK PDS study. The other studies didn't show as many benefits. So looking at the diabetes guidelines, the consensus we continue metformin. Metformin has benefits in terms of reducing insulin resistance. It also has slight reductions in weight as well. So I would probably put them onto both. Right. How many classes can be given to a patient whose sugar level is high and refuses to take drug? Well, every time you add on a new drug, you don't get the benefits that you see with the single drug. So you get benefits are low return as you add more and more benefit, more and more drugs. And I think I think there is some data showing after the fourth drug, there really isn't that much benefit in reductions in HbA1c. But these were data before we had the novel therapies of SGLT2 inhibitors and GLP-1 receptor agonists, which the pathophysiological mechanisms, the way they work, are very, very different. So I haven't seen data of four therapies. I think we've got some data on four therapies where they've been on traditional drug and a GLP-1 receptor agonist. That does happen now in clinical practice, and you do see reductions in HbA1c. Sanjeev's asking, tight glycemic control in old age increases chance of hypoglycemia. Well, as I said, this is inertia, the quaternary prevention, over-medicalization of patients. We need to assess these patients, first of all, what's their quality of life? Are they able to manage their medications? Are they taking their medication? Are they having regular meal? Are they losing weight? If they're getting frail and they're living on their own, or they're living in a nursing home, and they're all, after the age of 80, there's not going to be much of a benefit of HbA1c reduction. And, you start thinking about reducing. So someone frail, living alone, 75, their HbA1c is 7.9%. I think about possibly even reducing then as well. But it's again on the individual cases. So the best thing is really to reduce glucose-lowering therapies. But there's now also data that you can reduce blood pressure-lowering therapy safely. We did a systematic review of glucose-lowering therapy and showed that you can safely reduce glucose-lowering therapy. SGLT2 inhibitors in non-diabetics, well, DAPA-HF, DAPA-CKD, all of them showed that there are benefits in people with and without diabetes for heart failure and for kidney. There's the empagliflozin study again showing benefits in terms of heart failure and kidney disease. So there are data now that people with and without diabetes, you get similar benefits as well. As renal failure worsens, need for insulin decreases. It may be when renal failure worsens, these people often become frail as well. That may be one of the reasons. But you also reduce it because the risk of hypoglycemia is higher. As you know, the higher the lower the EGFR, the worse the risk of hypoglycemia. In some old patients, initial diabetes diagnosis has high postprandial sugar with the normal fasting uh, glucose. It does occur, but if they've got if it's a GTT you've done, then they've got diabetes, and you'd manage them as having diabetes. And which gliptin is safe? They all seem to be safe, but some you don't need to reduce the dose. So linagliptin, you don't need to the ROS, the dose. Vilda, we don't use much here in the UK, but for sitagliptin, we do have to reduce the dose. Diabetic patient with cachexia weight loss, can we start him on SGLT2 because there is absolute insulin deficiency or only insulin? Diabetic patient with cachexia weight loss, I'd think about that twice, about even insulin and SGLT2 inhibitor. You don't, if someone's frail, you need to find out why they've got cachexia. So until I've identified that, I don't think I'd put them onto SGLT2 or insulin. Unless if their blood glucoses were very high, then I may put them onto an insulin. But there is the risk for hypotension if patients are cachectic for whatever reason. DPP4 and metformin and SGLT2 food or that would I just ask them to take them in the morning, whatever's most convenient to them. The main one that we need to worry about is the oral semaglutide, which have to be taken on an empty stomach, then 30 minutes before a meal with a glass of water. Firoz is asking combination of dapagliflozin and sitagliptin. What's the outcome for this combination? I think it's a good thing. If patients are on combination therapies rather than single drugs, adherence is better. HbA1c reductions are better. The dapagliflozin will obviously have the beneficial effects in terms of HbA1c, cardiovascular outcomes, including hospitalization for heart failure, and for kidney outcomes. What the sitagliptin will do is reduce the HbA1c, so you'll get the macrovascular kidney benefits and the microvascular benefits because of the HbA1c reduction with the combination of DAPA and sita as well. Long-acting versus short-acting insulin, either depending on the patient. We normally start long-acting first, whether they've got CKD or not, and then depending on patient needs, we would put them into mealtime insulins. Obese patients having fasting hypoglycemia, yeah, happens, but again, all of these patients, we would just manage them as per the guidelines. If they've got a fasting 2-hour HbA1c, which are in the diabetes range, they've got diabetes. SGLT2 inhibitors, I just ask them to take them first thing in the morning with all the other medications. I haven't done intermittent fasting in people with diabetes, and I think this is something that would be frowned upon in people with diabetes. There are obviously the low-calorie diets, which is not the same as intermittent fasting, so they're still having a meal every day, and we know the low-calorie diets have led to reductions in weight, in fact, remission of diabetes as well. I would get them seen by an expert who has the expertise in meal replacement therapy. But fasting is something I wouldn't recommend. I mean, as you know, people fast during Ramadan, but they're fasting for a period of time, and then they're still having their meal at certain times. And again, there are guidelines of people who should fast for Ramadan and who shouldn't. The high-risk patients shouldn't, and they've all got instructions on the kind of meals to eat and when to take the medications as well. So quite complex area, this. Wow, those questions are coming thick and fast. Best time for DPP4 inhibitors? Again, I just say first thing in the morning. Right, Anand. Well, what I want to say is thank you very much. I think it's 5 o'clock. We're supposed to end there. Thank you so much for being with us. Thank you for listening. And thank you for so many questions. I hope I've managed to answer as best as I can. And I hope you all have a great day. Thank you. Bye-bye.